how to deal with that. During this webinar, I will focus more on the vertebral artery anatomy and also the approaches to reach the vertebral artery. Can you just open your video that I can see someone in front of me? So I'm sure that it is working because I have absolutely no feedback. So I see Vittorio Sivelli and Imad Ula. As Vittorio
I can
will
hear
be
you,
the
sir.
next one to speak about the angiographic aspect related to the vertebral artery. I will
Okay.
give you the floor in 20 minutes. So I will start by sharing my screen. Just a few seconds. I hope you will be able to see my screen. So as I told you, I'm Michael Bruneau, working in Brussels. I have some experience on the vertebral artery, and I will focus my talk now on the vertebral artery anatomy and the related surgical approaches. So as most of you know, the vertebral artery is subdivided into 4 segments. The first segment is the V1 segment, called also ostial segment, running from the subclavian artery up to the transverse foramen at the level of C6. Then the vertebral artery has an ascendant trajectory, which is called a V2 or transverse artery segment, because the vertebral artery comes and move into each transverse foramen from C6 to C2. At the level of C2, the vertebral artery make a lateral loop, then a upper loop, and then turn to enter the dura mater at the level of the foramen magnum. This segment is called the V3 segment or suboccipital segment. And then intradurally, you have the V4 segment. I put the V1 and V4 segments in red and the 2 other ones in blue because, in fact, it's important to understand that the V2 and V3 segment are in fact surrounded by a periosteal sheath, and surrounding the artery within the sheath you have an important venous plexus. It's why I put that in blue. This is a big anatomical difference and it has many surgical consequences. Compared to V1 and V3, which are truly the artery that is visible directly when you expose the artery. This is just the junction between V1 and V2, and you see here the periosteal sheath surrounding V2, and here at the level of V1, followed by the vertebral vein. This is a big difference when you are dealing with the vertebral artery. So on an anatomical point of view, there are a few branches arising from the vertebral artery. The most important one is the anterior spinal artery. Importantly, this anterior spinal artery never comes below the level of C3. Above the level of C3. It's always below. Above C3, you have an anterior meningeal artery, which is also important when you operated on foramen magnum meningiomas because it's one of the arteries feeding such a tumor. You have also muscular branches arising from the vertebral artery, V2 and V3 segment, and through those muscular branches, you have sometimes important anastomosis that developed in case of occlusion of the vertebral artery. What is important when you are dealing with the vertebral artery, exposing the vertebral artery surgically, is to know which type of vertebral artery you are exposing. And it's important to know the size of the vertebral artery. You are exposing the vertebral artery on the dominant side or the hypoplasic side. In fact, you can have most of the time equal vertebral artery, but in quite a significant number of patients, you will face a small vertebral artery. And if you face a small vertebral artery, in fact, there are 2 conditions. The vertebral artery can be called hypoplasic if the vertebral artery is fusing with the contralateral one to form the basilar trunk. In case of any damage to the vertebral artery, normally there is no consequences of that. It's not the case when you are exposing a small vertebral artery, just like this, but which is ending into a pica. This situation is completely different. It is called an atretic vertebral artery. And then in case of atretic vertebral artery, if in case of problem with the management of the artery, in case of injury, of sacrifice during the surgery, you expose the patient to devastating consequence with stroke in the posterior fossa because it's the territory of the pica. So it's a terminal supply. What are the other important anatomical variations that you have to know when you are exposing the vertebral artery? Loops can be present, and you have also an abnormal level of entrance, meaning that the artery is not entering into C6 but above. And we made a very large study about that, about the trajectory of 500 vertebral arteries. Normally, as you know, the vertebral artery enters the C6 transverse foramen. It is the case in 93% of the patient. But the vertebral artery can enter above into C5 in 5% of the patient, into C4 in 1% of the patients, and even more cranially in C3. Anecdotally, the vertebral artery can also enter into the C7 transverse foramen, but it has less consequences on a surgical point of view. You can detect that easily. I illustrate here sagittal MRI, and you can see the trajectory of the vertebral artery and where it enters the transverse foramen. It is visible also on axial slide, basically on MRI without any contrast. And you see here the vertebral artery in front of the transverse process, while on the other side, the vertebral artery is inside the transverse foramen. Clearly, it can be detected on angio-CT, again, inside the foramen, but in front of the foramen, meaning that the vertebral artery is not entering into C6, but above. You don't know the level, but you know that it is above. It is also detectable even on a basic CT scan, bone sequences. You see here a wide transverse foramen. You expect the vertebral artery will be inside. Here you see a very small one. The vertebral artery will not be inside. Is it important to know that? For sure, because when you expose the vertebral artery through a lateral approach, you will try to reach the transverse process and the bone in front of the transverse process, because it's where the vertebral artery is exposed, because normally the vertebral artery, when inside the foramen, the vertebral artery is protected by the bone. So if you cut the longus colli muscle and you are not aware of this variation, that the vertebral artery is not inside the foramen but outside, then you have the risk to injure the vertebral artery. So be very careful with such anatomical variation into the level of entrance, because you can start your surgery with a devastating complication. As I said, there are also medial loops that are important to detect preoperatively. This is a corporeal loop detected in 1.2% of the cases. It's not so anecdotal. And if you perform a basic cervical corpectomy without being aware of this, if you use a drill, you have a risk to injure the vertebral artery. This is a medial loop into the corpus. You have also medial loop into the foramen. That is clearly visible. And in this case, if you treat a disc herniation at this level, not being aware of this loop, you can expose the patient to a complication. It can be detected on basic exams and, of course, on angio-MR with reconstructions. You have also lateral loops. Those are of different types and mainly related to osteophytes, which are pushing the vertebral artery laterally. And in this situation, when the encarthrosis grows into the foramen, it can even result in a spontaneous obstruction and occlusion of the vertebral artery. Those are the lateral loops that can be detected. When you are exposing a vertebral artery at the craniocervical junction level, what is important to know, because it's quite common, between 5 and 20% of the patient, you can face a pica variation, with a pica not arising from the intradural segment of the vertebral artery, but arising extradurally from the horizontal portion of the V3 segment or even the vertical portion of the V3 segment. So the course of the pica is completely different. And here by sample, you have a course between C1 and C2, which can be truly problematic if you are not aware about that. You have a very rare anatomical variation related to the vertebral artery, meaning variation with the vertebral artery not arising from the subclavian artery, but from, by sample, the carotid artery. You have also fenestration of the vertebral artery here at the level of C2, with in fact the vertebral artery which has two trunks inside the periosteal sheath, it is called a fenestration. But if you have a duplication of the vertebral artery, you have truly two vertebral artery, one in correct position and the other one who has a different course outside the periosteal sheath. In this situation, coming and having a trajectory between C1 and C2. You have also very rare anatomic anastomosis between the carotid system and the vertebro-basilar one. You see all the connections that can be observed, the trigeminal artery, otic artery, hypoglossal artery, and pro-atlantar artery. Those anastomoses are very rare and sometimes associated with aneurysm, and they have to be detected preoperatively because they can be source of complication if you are not aware of that. An important aspect that has also to be discussed when you expose a vertebral artery at the cervical level or craniocervical junction level is when to perform a balloon occlusion test. In some conditions, it has to be performed. If the vertebral artery is minor, less developed, as I said before, you have just to extrude termination into a pica to avoid a Wallenberg syndrome in case of sacrifice. If the vertebral artery that you have to expose is equivalent or dominant to the contralateral one, you have to evaluate the risk of vertebral artery injury. The risk can be low or high. The high-risk exposure are related to the severe compression of the vertebral artery, the encasement of the vertebral artery in case of malignant tumor, if the patient has already been irradiated or operated on. When one of these criterions is present, the risk is higher to have a vertebral artery lesion during the exposure, and then it is better to perform a balloon occlusion test. If the balloon occlusion test is well tolerated, of course, you preserve the vertebral artery. If it is less or not tolerated, then you have to be prepared to perform a bypass if needed in case of any difficulty with the exposure. So what are the approaches to the vertebral artery? At the cervical level, it is called the lateral approach, and it is a little different from the classical anterior approach that is used to perform any disc herniation or anterior access to the cervical spine. In which way it is different? In the anterior approach, the dissection is performed medially to the cervical vessel, meaning the internal jugular vein and the common carotid or internal carotid artery. In the lateral approach, the superficial layers are the same. The incision is at the level of the medial border of the sternocleidomastoid muscle, which is put laterally. And then the dissection is performed laterally to the vessel with the goal to reach the bone in front of the vertebral artery at the level of the transverse process. In front of the transverse process, you have the longus colli muscle, and above the longus colli muscle, you have the sympathetic chain. So this is the approach at the different level of exposure of the vertebral artery, V1, V2, and V3. At the level of V1, the incision is performed along the medial border of the sternocleidomastoid muscle. You can perform a contra-incision over the clavicle. As I said, lateral dissection along the lateral border of the internal jugular vein with a coagulation section technique, meaning that first you take the tissue, then you coagulate on it, and then you divide it, and then you work in a perfect, clean surgical field. At the level of C6, you may have to divide the omohyoid muscle to enlarge the access to this level. The approach I will detail later on for the craniocervical junction is in fact the same dissection along the medial border of the craniosternomastoid muscle, and then turn around the mastoid, and you will have through this access an approach to the level of C0, C1, C2. So what are the tips and tricks? As I have said, if you would like to work confidently, you have to reach and target the transverse process where the vertebral artery is protected by bone. Then you have to perform a superosteal dissection. This is the first key point. The transverse process is a bone protection, and then you have to palpate it when you have performed your approach to know where the vertebral artery is protected. Then you divide the longus colli muscle above the two consecutive transverse process, and doing that, you know that you were perfectly confidently, and you will be able to expose the deep field just in front of the vertebral artery. Of course, we have dissected previously the sympathetic chain, and you can protect the sympathetic chain with the aponeurosis of the longus colli muscle that is turned around and that is maintained in place with some sutures. So the superficial dissection, what is this concept? The most important concept when you expose the vertebral artery. As I told you before, V2 and V3 are surrounded by a periosteal sheath and by a venous plexus. What does it mean on a surgical point of view? If you directly go with your Kerrison here to open the anterior branch of the transverse transverse foramen, you will directly injure the periosteal sheath, then the venous plexus, then you will face troublesome venous bleeding, and that is very uncomfortable. If you would like to work in a perfectly clean surgical field, in fact, you have to divide the periosteal layer in front of the transverse process. And then with a spatula, you elevate the periosteal layer outside and then inside the transverse foramen, making that the periosteal layer stay in place along the periosteal sheath of the vertebral artery. So it's in continuity. And then when you use your Kerrison at this level, you are perfectly safe and you will not disrupt this fine layer and you will not have any venous bleeding at all. This is the opening. And if you would like to mobilize and transpose the vertebral artery, then you have to put your spatula inside the transverse foramen and again elevate the periosteal layer, and then you will be perfectly clean for your surgical exposure of the vertebral artery. Just take care at the level of C6, the lower level where the periosteal sheath reach the transverse foramen, you have a ring, and this ring is sometimes a level of more adherence. So if you have a bleeding problem, you can control the venous bleeding with direct coagulation on the sheath itself, or you can even pack with Surgicel and then, or use Flossil, and then you will be perfectly able to control any bleeding around the vertebral artery, meaning venous bleedings. So what type of tumor you can treat with the lateral approach to the vertebral artery? Many tumors, parapharyngeal tumors, soft tissue tumors, bone tumors. There are a wide variety of bone tumors, primary one, but also metastasis, secondary one. You have also extramedullary tumors. Those are the type of extramedullary tumor extremely interesting to treat with a lateral approach, meaning not the one which are intradural, purely intradural, but the one which are by sample dumbbell shaped. And the interest of using a lateral approach compared to a posterior approach is that you can remove all the components of the tumors. You have not to perform a facetectomy. You will be confident with the vertebral artery which is exposed, and you will devascularize the tumor at the first steps of the surgery. So there are a lot of interest to make those surgeries through a lateral approach. And this is a case to illustrate that. The patient was sent to me after having been operated on by a posterior approach. What does it mean? The surgeon performed a facetectomy. The patient complained of cervical pain. The foramen is enlarged, and finally, the residue is growing because the tumor is not completely removed. And when you see the lateral approach, you see the exposure you have. This is the vertebral artery at the level of C3. This is the loop at the level of C2. The foramen is enlarged by the tumor, and by this lateral approach, you have an access to all the structure after a superficial dissection of the vertebral artery. This is the exposure of the vertebral artery. This is the final exposure. This is the tumor. And then you have just to resect the tumor by an intratumoral debulking, then a peripheral dissection, and you see the situation at the end of the procedure. This is the lateral artery completely decompressed now after complete resection. Of course, bone tumors can be treated by this lateral approach. This is a chordoma. You see how it is destructive at the level of C2, C3. I just showed that to illustrate that at this level you have to spare the 11th cranial nerve, and then you have to be a little imaginative if you want to perform a reconstruction if needed. This is a distractable cage put obliquely with a unilateral fixation. This is a plate with two screws, one above and one below. So the lateral approach is also very interesting if you would like to decompress selectively a nerve root compressed by oncodiscarthrosis. In this situation, we published that with Bernard Georges. We can selectively remove the compressive element without any need for fixation. So now, what are the approaches to the vertebral artery at the level of the craniocervical junction? I speak until now to the exposure at the cervical level. Now, at the craniocervical junction level, there are basically two approaches, the anterolateral approach and the posterolateral approach. The posterolateral one, you are very familiar to this approach. This is a basic midline approach with some contra-incision towards the pathological site. It is used by sample to treat foramen magnum meningiomas, and I refer here to the classification developed by the Professor Bernard Georges. You have also the anterolateral approach, as I say, which is the upper extension of this lateral approach, dedicated to treat lesions, but which are not intradural as for the posterolateral approach, but extradural lesions at the level of the occipital condyle, at the level of C1, C2. It's also a way to reach the jugular foramen. Technically, you have to leave just a cuff of 5 millimeters of muscle when you divide the sternocleidomastoid muscle to reapproximate it at the end of the surgery. Again, the exposure is performed laterally to the internal jugular vein. You have to spare the 11th cranial nerve and to reach the transverse foramen at the level of C1. Importantly, you have to understand, and it is quite unique, that the anatomical relation of the vertebral artery are changing at the level of the craniocervical junction depending on the position of the head. Because C1 is moving laterally and anteriorly, if here in this situation, the head is moved towards the right side, the left transverse foramen will move anteriorly. And then in neutral position, both segments above and below the C1 transverse foramen are perpendicular, but when the head is turned, both segments become more and more parallel. This is truly important because all anatomical relations are changing at this level depending on the head position. And depending on the region that you have to reach, you have to turn more or less the head. This is the exposure I have just detailed. When you reach the C1 transverse foramen, you have to divide the muscle inserting into it, superior and inferior oblique muscle, and then again perform this superosteal dissection to elevate this periosteal layer, then open the foramen with your Kerrison, and then you are able to mobilize the vertebral artery to transpose the vertebral artery if you have to reach anterior structures. And just a case to illustrate, in fact, both approaches. This is a child with an aneurysmal bone cyst, and you see the evolution within 6 weeks. Very evolutive, fast-growing tumor. The patient received first a percutaneous embolization to decrease the blood vascularization. It's a very young children, 6-year-old, so it's not so many blood reserve. The first surgery consisted in a lateral approach, and by this lateral approach, you see the exposure of the vertebral artery at the end. The main component of the tumor was removed. Even a graft, iliac graft, was put inside a destroyed C2, and you will see that after a few months, this graft is completely inserted. Then the patient is turned in the prone position. The posterolateral approach is performed to remove the posterior aspect of the tumor and then to perform a fixation in order to restore the stability at this level. And I put here a graft, also a bone graft between C1 and C3 in order to make the fixation stronger. So those are the aspects I would like to develop with you. I cannot end this talk without speaking about my former trainer, who was Professor Bernard Georges. I learned everything about the vertebral artery thanks to him. So I would like to finish this talk with a short memory to him. Thank you for your attention. So I will stop to share my screen. And I see that also Paolo Di Rosso joined us. He will be the third speaker. I will have to leave a little earlier. I will not be able to stay until the end. So it's my pleasure now to introduce the next speaker, and I propose that Paolo introduce then the other speakers afterwards, who is Vittorio Sivelli, who will speak about the angiographic aspect